We've heard a lot about metrics and a lot about publishing and a lot about the H index. And Michelle and I have had some very serious conversations about it this past year. And I think it's probably something that a lot of us who are quite deeply embedded within the clinical laboratories think about. How do you publish and have an impact when your clinical load is so high? At the same time, we're in a department of laboratory medicine and pathology. We get to see phenomenal material that comes across our desks and into our labs. And we have incredible colleagues across the department, some of whom are basics, some of whom are translational research, and some of whom, like us, are clinical. And so the idea here was, how can you have an impact coming from the clinical side of things, working with small n's, and sometimes a case, the n is actually only 1. And as with many things, frequently we discuss these kinds of things that we're discussing between ourselves with other colleagues in the department. And in particular, this time we discussed it with Dr. Harry Orr, who's a close colleague and has always been a mentor, not just so much in the words he chooses to share and the resources that he shares with all of us, but also with the example that he has set for all of us in terms of research productivity. And so, although he can't be with us today, he is with us today.
Generally, it is a private matter, but times have changed. I don't generally share mine, but let me just say that it would be sufficiently high, from what I have been told recently, to meet criteria of a professor at Johns Hopkins several times over. So the H factor actually, to a large extent, started with an informal conversation I had with an individual from a single family and their family's pedigree, and how the various aspects of the disease in this family might be of interest to me. And I bring this up because what can start out as seemingly a small conversation can, over the years, really develop into what I think was an impactful group of research in science, and not to mention having a higher than average H index.
All right, so I'm just going to get my transition here. So what is the H index, actually? I must admit, I had no idea before I started preparing for this grand rounds what it really was. We certainly heard about it. And it turns out there is a tremendous amount of scholarship just based on the H index. I mean, you could increase your H index simply by publishing on the H index. So it, just very simply, it's a measure of the productivity and impact of a researcher's publications based on their citations. And it's defined as the number of papers, H, with a citation number that's greater than or equal to H. And I will show you graphically in a minute. So bottom line, in plain words, if a researcher had 25 papers, 10 of which had been cited at least 10 times, their H index is 10. So it doesn't matter how many papers you have, what really counts is the number of citations. So graphically, it's just the point at which the number of citations and those numbers of papers are the same. And there is actually a rather impressive amount of mathematics that goes into this. So we thought we'd start out with just a little quiz. What does the H stand for? Stand for Hirsch, high impact, hypothetical, hedonism, or none of the above.
What about all of the above?
So, anybody for A? Hands up. Okay. B? C? We're going down the line here. So actually, it is for Hirsch, although it's perhaps not what you think it might be. So this
H-index was actually begun by a physicist named George Hirsch back in 2005. He is at University of California, San Diego, and he very modestly named this index as H. But some of us struggle, of course, with actually wondering what our H-index is, and sometimes, as it was for me, it can be a bit of an eye-opener to find out what it actually is. So it's important to know what goes into the H-index, because a number of things can impact it. So the calculations for these, for the number of citations is drawn from a number of online data sources. The top three are Scopus, which is owned by Elsevier, Web of Science, owned by Thomson ISI, and Google Scholar, which is a publicly available database. What's important to know is that an individual's H-index can vary somewhat depending on which of these databases are being used for the number of citations. Now, as with any measure, particularly a measure that's trying to take a very complex topic, a very complex representation of a researcher's work, and summarize it or distill it down to a single number, there's going to be limitations, but also some strengths. One of the major strengths is that it does provide an objective measure of a researcher's influence in the field. That is, it's not just looking at the quantity of papers that are put out or their productivity, but it also is a representation of the quality. That is, what type of impact have those papers had on the field. And, as one of the perhaps few benefits of aging, this increases with time and cannot decrease. Now, the limitations of the H-index include, one, that it's difficult to compare H-indices among researchers in different fields of study. So what is a very good H-index for a physicist, for example, may be considerably different than a good H-index for someone in the biomedical sciences. It can be manipulated by self-citation, but that's obviously the few bad eggs. It also does not represent author position. And there's been considerable discussion in the literature as to the impact that author position should have, i.e. is it fair for a middle author on a 100-author paper to be able to claim the same H-index or reap the same benefits of that as the first or last authors. Some of these online data sources may not accurately reflect all scholarly output. That is, they may not include book chapters, conferences, policy papers, etc. And as we mentioned, it cannot decline with time, but also it cannot decline with inactivity. So therefore, an emeritus professor, for example, or someone who has been inactive in their field for a number of years may still appear active by their sheer quantity of their H-index. And also common last names can make it difficult to calculate an accurate H-index, which means that, we'll talk about this in a little bit, but it can be helpful to make your name that you publish under as individualized as possible, for example, using middle initials. So it is important when reviewing one's H-index, which is an important thing to do, to know which data sources are being used. So for example, the Web of Science, which is what we have available through our institutional subscription, limits the search to those journals that are listed in Thomson's ISI database. And for those non-ISI journals, it will only cite the citations for the first author. And there is somewhat limited coverage of non-English sources. Google Scholar, on the other hand, which is a more recently developed and, as I said, public database, does include some of those non-scholarly citations. It does a better job of representing book chapters, policy papers, etc. However, it may underestimate those titles published earlier. Again, this is a much more recent database. One thing for us to remember is that in our field, it may not appreciably differ whether we use Google Scholar or Web of Science. But again, it is something that I think is helpful to try both ways and see which might yield a higher H-index. So the easiest way to calculate one's H-index based on Google Scholar is to use a freely downloadable software program. It's called Publish or Perish. It's now in its 5th version. And I recommend you go to this website. It's by a British researcher. Her name is Anne-Will Hartzing. She has a tremendous website, and her major area of research has been international management and human resources, but she has kind of developed this side area of research of looking at publication metrics. And it's her website, it's she who has developed this Publish or Perish software. It calculates the H-index based on it, so it normalizes for the position and the number of authors, and so therefore it better approximates a per author impact. And I'll just say that as kind of a benefit of actually showing up here for the last grand rounds, we do have this program on a jump drive that Amy will have at the end when you leave.
Wow. Chips.
So with that, we will transfer. So Betsy and I are going to just be kind of going back and forth a little bit this morning.
So we thought that we would give some examples of how in the cytogenetics lab, and also because this is also a molecular pathology and genomics talk, we've used some of our interesting cases to do what we think is impactful science. And this was actually one of the first cases that I saw as director in the lab. There was a patient who presented at 6 months of age with Wilms tumor, favorable histology. There wasn't anything too much remarkable about this patient other than the fact that they were very small. Their weight was less than the 5th percentile. The tumor was surgically resected, and then according to a protocol that they were on a children's oncology protocol. They received multiple chemotherapy agents, some of them quite heavy hitters. The patient responded very, very poorly to this chemotherapy. They had very toxic response to it, severe pancytopenia and septic shock, mucositis and pancytopenia. And 1 year after treatment, they developed acute myeloid leukemia. This is a very unusual type of course for a patient who presents with Wilms tumor, which is a fairly common tumor. They got high-dose cytarabine for the AML, and then unfortunately passed away as a result of toxicity of that treatment. The second patient, who came within a year of that first patient, was 27 months old. And this patient did have some multiple congenital anomalies. Their actual presenting feature was an ataxic gait that they'd had and a lack of coordination for 10 days. Although they were normal birth weight, they had congenital heart anomaly, they had some developmental issues, mild hypertelorism, small eyes, multiple hypo and hyperpigmented skin lesions. This patient was diagnosed with a medulloblastoma, and there was total tumor resection, again, based on a children's oncology protocol, received chemotherapy, and died of lethal toxicity. During this time, there were a lot of consults that were requested by the referring physicians. They saw geneticists. They sent out for radiation types of sensitivity studies, which were done at that time in California. They actually entertained the concept of potentially this being a Fanconi anemia or other kind of chromosome instability, bone marrow failure disorder, and everything was negative at that time. Unfortunately, within the next 2 years, so while these patients were still alive, these parents, each of these families, gave birth to another affected child. So the sibling to the first patient developed T-cell acute lymphoblastic leukemia at the age of 5. This is a very young age to present with TALL. And the sibling to the patient who presented with a medulloblastoma presented with Wilms tumor at 15 months, and 3 years later, a medulloblastoma in addition to this. The parents in both of these cases, in discussion with the physicians who had treated the siblings of these patients, decided and declined. They okayed surgery, but they declined any chemotherapy without knowing the basis for the sensitivity. There was enough similarity that they felt that they would not go that route. We received specimens from the tumors, we received specimens from skin, we received specimens from blood, although in the case of the leukemia, the blood was involved. And as I think many of you know, the University of Minnesota is a center for bone marrow failure disorders, and in particular, there's a comprehensive center for Fanconi anemia. And we actually developed the mitomycin C and DEB dual testing in our lab and brought that up running here. So when we looked at the chromosomes of these patients in non-affected tissues, what we saw was a somewhat remarkable constellation of things. First of all, without adding any kind of cross-linking agent or anything else to the cultures, what I saw was a very high rate of chromosome instability, much higher than one would see in a Fanconi anemia patient, typically, and certainly much higher than one would see in a control. And there was a certain type of chromosome rearrangement that we observed in those cells of both of these patients. In addition, when we stressed the cells with cross-linking agents, mitomycin C and DEB, we saw very characteristic findings of Fanconi anemia, which, for those of you who are familiar with this disease, the abnormality that is frequently talked about is the so-called radial figure, which is chromosome breakage and exchange between chromatids of a chromosome. And so we saw kind of classic breakage for Fanconi in the context of being treated with DEB and mitomycin C. But again, atypical was the finding that the baseline breakage, and these were in non-treated, so this patient had not seen any kind of chemo that would cause that breakage, we saw a very high rate of chromosome instability. So it was, yes, it was Fanconi by the DEB and mitomycin C, but it was something else going on according to the constitutional breakage. And I think this kind of gets to the point of that I know we mentor in terms of faculty within the department to pick an area of expertise that you think you're going to focus on, because the more you see of that, the more typical things you see, the more you're going to be able to call out an atypical case when it comes your way and be confident in that call that this is atypical. In addition, and this is just a chromosome karyotype from the T-cell leukemia, this is a very unusual karyotype for T-cell leukemia. There are certain known recurring abnormalities that one sees in T-cell. This is not what you typically see. This has actually a lot of chromosomal duplications and rearrangements that one could think about some kind of homologous recombination going on. So what do we do at this point in time? The physicians are extraordinarily anxious for us to make a call. Is this Fanconi, is it not, regardless of what had been shown in the past? And two, how can they possibly move forward with therapy? Is there anything they can offer these patients that is not going to result in this increased toxicity? They actually asked us in the lab to try a lot of different types of in vitro experiments with different types of agents, and we did do that. The fact is that almost anything that was put on these cells from these individuals caused tremendous amounts of chromosome instability. So at this point, in this period of time, which was early 2000, we didn't have sequencing NGS in our institution. And actually the way that Fanconi anemia diagnosis more so than just the hallmark, which is chromosome breakage and rearrangement, which to this day remains the gold standard. We needed somebody who could do complementation analysis, and decide if these cells were operating according to one of the known Fanconi mutations. Because I traveled to the Fanconi meetings and read the literature, I knew that Alan DeAndrea at Harvard was the person who probably could best at Dana-Farber, could address these questions, and I called him. I didn't know him personally, and I think this is another kind of message that when you are reaching out to take your clinical case one step farther, it's okay to contact people who are known in the field, and they'll let you know if they're interested or not interested. And I described the case to him, and he was interested, but he was in the midst of doing something that was very, very impactful. So he put the cells aside for a year or two. But we did send it to him in the year of 2000. He confirmed that they were hypersensitive to my methylene C. He felt he needed to do that, and that was fine. And he then told us that these cells were not one of the common complementation groups. There were only 8 known at the time, and each complementation group essentially corresponds to a different gene mutation. Dr. DeAndrea's laboratory at the time was in the process of identifying a novel Fanconi gene. And that gene actually was BRCA2. So all of us are familiar with BRCA1 and BRCA2. But what was unknown was that BRCA2 actually is a Fanconi anemia gene. It belongs to the FANCD1 complementation group. And the reason that it was such a unique finding and such an important finding for the field is that prior to this, it had been thought that biallelic, so when you have 2 mutations within BRCA, one on each of your, in this case, chromosome 13, which is where BRCA2 maps to, that was lethal, that you couldn't actually sustain life with a biallelic mutation. And so Dr. DeAndrea's laboratory identifying that as being a possibility was a major breakthrough. He did it on cell lines. He then became more interested in our cases, and he did pull them out of the freezer, and he identified biallelic BRCA2 mutations in each of the affected younger siblings. So both of these siblings had biallelic BRCA2 mutations, and clearly their presentation was very different. You don't think about Fanconi anemia presenting with early onset solid tumors, and in fact things like Boehm's tumor or medulloblastoma, or very early onset T-cell leukemia, and the very, very early onset of AML in these patients. So this was the first association of solid tumors of childhood with BRCA2 biallelic mutations and Fanconi anemia. And we then kind of talked about specifically the unique cytogenetic profile that we would see in the lab, very high levels of spontaneous chromosome breakage, typical hypersensitivity to DEB and mitomycin C, and very complex tumor karyotypes, suggestive or at least consistent with something going on with homologous repair, which is what's shown to be involved in the repair of crosslinks that's aberrant in Fanconi anemia. And this resulted in a high-impact publication in Blood, and clearly did a lot of good for my H-index, but in addition, it also changed clinical guidelines, because now Fanconi testing for children presenting with solid tumors who are small for gestational age or other kinds of congenital anomalies are recommended to have Fanconi testing, and FA testing for those patients who present with increased spontaneous breakage and rearrangement. And Michelle and I have had cases where they have children, I know one from St. Cloud, transferred to the NICU here, asked us to just do a chromosome study because the child had multiple congenital anomalies. We were looking at that chromosomes the same way we would look at any newborn from the NICU, so it wasn't a specialized culture or anything, and we saw the characteristic findings that we had seen in these BRCA cases. We asked the physician, could this be a Fanconi? They said no. I said, you know, I think it could be one of these new subgroups, is there any kind of family history of breast cancer, etc. They did the testing and the case was positive. So it's also changed the way we look at kids who present with beta and other kinds of developmental sequences. At the time that this work was done, there were only 8 complementation groups known, and people were already starting, and there had been doing this for a long time, to create the diagrams that talked about the core complexes, the Fanconi core complexes. There are 3 of them that interact with other genes to enable cross-link repair. The repair of double-strand breaks, as many of you know, is lethal, and so one wants to repair that damage. And I bring this up because at the time of that work, there were 8. This is a table that I made very recently for today's grand rounds, and it could be different within a month, because there now are 20 genes that are identified as Fanconi anemia genes. And I think that what's really interesting is if you look here, you have actually BRCA1 now, you have RAD51, you have BRIP, you have POLB2, RAD50C. Many of these genes are breast cancer and ovarian cancer susceptibility genes. And what this means is that it's again changing the landscape of who we should be looking for in terms of Fanconi testing and what that testing means, not just for the individual, but potentially for the family. And although that paper in Blood was quite a long time ago, there have been papers within the last month, and here are 2 very high-profile papers from 2015, each of them based on an N of 1. One patient who presented with biallelic mutations in BRCA1, who presented with Fanconi anemia, a subtype of Fanconi anemia. It was always known that the Fanconi anemia genes interacted with BRCA1 and RAD51, but this is actually saying that one can have, in this case, biallelic mutations of BRCA1, almost identical to the situation we had with the BRCA2, that can yield you to have Fanconi anemia subtype. And these patients may not be presenting in childhood. They may actually be presenting in adulthood. They may be presenting with solid tumors of some of the types that they get, head and neck, gynecologic tumors. And then a paper in Molecular Cell. This actually was very interesting because, with the exception of one X-linked gene of the Fanconi genes, all the rest are autosomal recessive. This is actually the first dominant mutation of the Fanconi anemia genes, and it's in RAD51, showing again that you can have heterozygosity. And this patient, I will have to say, actually, we have seen in our lab, we called it positive, others called it negative, and it wasn't until this paper, until they actually worked out the cloning of this gene and also functional studies, that it was actually then labeled as a Fanconi anemia gene. So in molecular pathology and genomics, we're in an age of discovery. And I think we're in a really terrific position to be able to capitalize on the techniques that we have, in addition to the very, very knowledgeable clinicians that we're surrounded by. We're very fortunate to have the tools that we have, and we also have funds that will support us taking a case to the next step. We have a lot of opportunities within the academic health center and within our own department. So the take home from this was that single cases and small series of cases can have major impact in the field, both scientifically and clinically, and that we need to reach out for scientific collaborations to extend the impact of the clinical observation. I know with the pressure to publish, sometimes we're thinking, okay, we'll write this up as a case study. But I think now, one of the things Michelle and I have done is to step back and say, how do we take this to the next step? Is there anybody within our institution? Is there anybody we've heard talk at Grand Rounds? Is there anybody we've gone to meetings that we know has this as an area? And can we partner with them? I think that Alan Dandry was very happy to partner with us to be able to bring this. He didn't have those patients. They were rare. And many times you have basic researchers who don't have the clinical and are very happy to have that, and the clinicians were also delighted to be part of that. The next example, actually again, is with Fanconi, but it talks a little bit about now what we have right now. We didn't have NGS at the time that those other cases came to our way. But this is a case with a Fanconi who presented with myelodysplastic syndrome, MDS, who was presumed to be a FANCD1. So she was thought to have a biallelic BRCA2. And this is because the patient's mother had passed away from breast cancer and had a known BRCA2 mutation, and it was inferred that this patient was therefore most likely a FANCD1. And a skin sample, because her blood obviously was involved in her malignant hematologic malignancy, was sent to Myriad, where the mom's mutation had been documented for testing. And Myriad found the same BRCA2 mutation as the mother in a heterozygous state. We all received, so hempath, flow, molecular, cytogenetics, all received specimens. And she had a complex MDS karyotype, characteristic of what we would expect to find in a Fanconi patient. I won't go through that. But in addition, we ran microarray, which we are now very frequently doing on the front end of our MDSs and our acute leukemias. And what we found was, in addition to the abnormalities we expected to see, based on the karyotype, we found a small 6.4 kilobase deletion within FANC-A. We also found on the array, on chromosome 13, although there was no copy number gain or loss, you're all sitting at 2 copies here with a ratio of 0, we found loss of a middle tract, which is loss of heterozygosity for chromosome 13. So BRCA2 maps to chromosome 13, and this was highly suggestive of a mutation on a gene within chromosome 13 that was now present in homozygous state. Fortunately, we have our molecular colleagues who did an NGS study and also detected the FANC-A deletion by NGS, so very in agreement with what we found. But in addition, they found something we would be unable to see in cytogenetics by array or by G-banding or by FISH, and that is a point mutation in a second copy of FANC-A. So they found a G to C splice site donor mutation. So now the patient has biallelic mutations in FANC-A. This would make the patient FANC-A, not a FANC-D1. They did find a heterozygous 2 base pair deletion within BRCA2. So again, confirming what the Myriad had shown. But again, there's only 1 copy of this deletion. So what we believe is going on here is that this patient is actually a FANC-A patient, germline, but her tumor cells, those that were involved in the MDS, actually acquired loss of heterozygosity for the BRCA2, for the FANC-D1, and therefore the tumor cells are homozygous for that BRCA2, but the germline is FANC-A, which again has ramifications for this family. It also lets us know that we need to start thinking about Fanconi mutations within MDS and within AML and within the solid tumors. So we know that these patients have a predisposition to malignancy, an 800-fold risk for AML, but also an increased risk for solid tumors. And again, we have a large cohort of expertise at the university for opportunities for us as we see these cases or interesting cases, be it in SurgePath or heme or molecular or cyto, to move these cases forward to impactful science. So this next scenario kind of emphasizes what happens when you take a case or a couple of cases and move it forward by really joining a much larger group than just one other investigator. So this was one case of an infant with acute myeloid leukemia who had a rearrangement between chromosomes 7 and 12, a fairly subtle translocation that disrupted ETV6 on 12p. And within actually several months of having this case, we saw a second one. We then didn't see another one for years, but we did see those two within the first couple of months. The second case looks very different, but yet it also was an infant with AML. And one of the things I think that people in the clinical labs that we like kind of these puzzles, we said, well, the breakpoint on this 7 might be very, very different. It's clearly up here and not down here. 12p looked the same, but it's got to be the same. It has to have some bearing. And we figured out that in point of fact, there was a break here and a break here, and this region was then inserted into 12p. So it gave you the same junction, which we now know to be an MNX1 ETV6 fusion. And these patients did very, very poorly. But you can't decide risk factor for a cytogenetic abnormality or any molecular abnormality based on 2 cases. You need very large series. And when you're dealing with rare events, you need especially to think about how can you become part of a larger group. So in this case, the group that we're involved with intimately is Children's Oncology Group. There are 2 very large-scale studies on acute de novo acute myeloid leukemia and COG, and you can see that the first study had over 1,000 cases. The second one is still accruing, and it's at 1,562 cases. And because I'm the cytogeneticist for AML within COG, one of 2, we get to look at all of these cases. And so I was, in particular, interested in what happens with 12p and ETV6 rearrangements within this larger cohort. Could we say anything about it? And we recently looked at that data, and you can see that this is your 12p down here, and these are AML. De novo AML in pediatrics is not a good disease to have, but this one is this abnormality is an extremely poor risk factor. So the issue here is risk stratification, characteristics of the patient and disease that are used to guide therapy. Many of us in the clinical lab get calls, should we take this patient to transplant? Should we keep them on maintenance chemo? What are you recommending based on what you're seeing? And so in most cases, you have high, intermediate, and low risk based on established correlations with disease outcomes, such as event-free survival or overall survival. Right now, the high-risk classification and low risk for AML in pediatrics is minimal, and it's been this way for decades. There's 3 abnormalities that will place you into high risk, and there's 2 that will place you into low risk. And everything else is standard risk, which means there's a lot of patients that aren't getting treated optimally because their cytogenetics are just put in this heterogeneous standard bag. So one of the things that we've been able to do with Children's Oncology Group is to look over these very large numbers of cases of survival characteristics and relapse rates, minimal disease rates, and come up with new risk stratifications for AML. And you can see that there's quite a large number of abnormalities. Some are within specific gene families, and our goal now is to develop in our lab the diagnostics, or in combination with molecular, the diagnostics that will help us to identify these upfront for these patients. Many of these also apply to adults, but again, this is a pediatric limited group. And so I think that this will probably be a high impact paper. But one of the things that I'm probably most proud of, in a way, although it will do nothing for the H-index in this case, is the fact that there's a new volume of the WHO classification coming out within the month. And in the WHO, there has never been any special recognition of pediatric AML. All of the AML is just in one large group. And we really were asked to submit data in support of pulling out pediatric AML, which we did and was accepted for the WHO in the form of a supplemental table. So I don't think anybody's going to cite a table in the WHO, But nonetheless, there are tables of these abnormalities that we see that are much more frequent in pediatrics or actually specific to pediatrics. We know this is a volume that's used by many clinicians and many laboratories worldwide. And so we were very happy to have this table and to be able to have an impact really clinically based on the findings. So it is an example of a case where you take your small cases, you think about them and see, does this really pan out in the larger, or was that just some, special case that we had, a one-off that you might say with those 2 early cases with the 712, but it doesn't appear so, it's held out. And I know that the European groups are also looking at this now and also seeing, based on what they presented at meetings, the same type of very poor response to standard therapy. And now the issue is for those to come up with perhaps better targeted therapies based on what one knows or hopes to learn about the abnormalities. So the final case that I'm going to present, before I turn it back to Michelle, is actually an observation that's fairly recent in our lab, for which we don't have publications, but we thought it was important when we were sorting through the many cases to present on how does one start this process of thinking about a case and how to take it to the next step. So this is a patient who actually had a lymphoma several years ago, was treated for that lymphoma, and then showed back up in clinic with poor white counts and neutropenia. And when we looked at her cytogenetics, we found kind of classic findings for a myelodysplastic syndrome, an emerging myelodysplastic syndrome, a deletion of 5q. In addition, there were abnormalities of 17 and 20. This is 17q down on 20, and there's 20 in here. There's 5 in there. And when we ran an array to try and figure out if we had balanced translocations or fusions, etc., there was also a deletion on chromosome 1. And the first study was done in 2015, and then with very little progression, she was not called MDS in 2015. Her cytogenetics were suggestive of it, but clinically she was not. Recently, in 2017, she reappeared. She's been followed all along, and again, now they're starting to see some findings, but again, we can see from the arrays that were run the identical loss in 1P. We could see that it hasn't changed at all. It was present in 2015, present in 2017, and was visible in the G-bands. We see a small region of loss on chromosome 17 that has to do with where that interchange was between 17 and 20. And then you can see on chromosome 20, a small deletion again at the breakpoints, so that even though this looked like a balanced rearrangement, it wasn't. There was loss of material. However, what was very unique about this patient was the array findings on chromosome 5. So if you remember the picture, we thought, well, there might have been a deletion and some additional extra little material here, but there's no way to take this picture and go to this. When you have this number of losses, back to normal, deletion, back to normal, deletion, back to normal, deletion, normal, deletion, normal, deletion, normal, all along. And if you look over 2 years, this has been remarkably stable. So what is this that we're looking at? It's actually a new concept in cytogenetics. It was discovered years ago, but known as chromothripsis. It means the shattering of chromosomes. So rather than have a stepwise progression in the development of an abnormal clone or leukemia or a solid tumor, one actually has one catastrophic event in which the chromosome is shattered, and then the chromosome reanneals with deletions and potentially new fusions. When we're looking at, the array, we're looking at the pieces that are remaining, But this doesn't tell us the order in which they are reassembled. This just tells us presence or absence. So the question now is, how frequent is chromothripsis in our, in this case, therapy-associated deletion 5 cases? We know that deletion 5 plays very differently across different subsets of individuals. Can chromothripsis account? Are some truly chromothripsis and are some just normal deletion? It's all an issue of trying to get at that heterogeneity. And I think in order to do this effectively, we need the help of molecular to look at potentially, are there any true fusions that are coming out here? We need certainly our clinical colleagues, somebody like Erica Warlick, who's an expert in MDS. We have a large epidemiological study of MDS. Minnesota has one of the highest, I think the highest rate of MDS in the country. So is there anything related to exposure? But there's many possibilities for how we take a single observation, and this is actually our third observation, and then move it forward to have impactful science. Also, what does it mean for us doing arrays, or how we approach the analysis of cases in cytogenetics? So with that, I'm going to turn it back over to Michelle.
Well, I know that
Betsy.
we planned that, yes, and she's used to this. So I don't know about you, but I often will benefit from having a deadline. So this is a little countdown clock that I'll just point out to Dr. Firk that this is noted for July 1st, 2020, so this is my promotion. Yeah, so just bear in mind, this is my promotion countdown clock. I can send this to you if you would like it to have it on your screen.
It's already.
So just so you know, on your jump drive is also a version of this countdown clock. There's a lot of countdown clocks out there, but this is one that kind of is long-term, which is what I'm looking at. So, as Betsy has summarized, there are many ways that we can take these individual cases or small n's and publish them. But one thing to bear in mind is there's a tremendous amount of publications every year. And as you can see, it's just essentially skyrocketed exponentially to the almost 1 million papers in Medline published per year. So how do we try to make an impact in that? This is also an interesting article that was brought to my attention by Dr. Orr, which takes the first page of every item, which are now over 58 million articles that are indexed in Web of Science. And if you took just the first page of those, that would reach almost to the top of Mount Kilimanjaro. So one thing to bear in mind is that of these millions of papers, 25.3 million of them have 0 citations. So no impact on your H-index whatsoever, because remember, H-index is citation-driven. 18.3 million have 1 to 9 citations. 13 million have 10 to 99 citations. And 1.1 million have up to 1,000 citations. And now we're getting up to the top 100 papers. This article was about the top 100 papers that have been published. It would be the top centimeter of this Mount Kilimanjaro stack of paper. So one thing I think that this highlights is that we have to look not just at numbers, but we have to look at impact. So as Betsy has so nicely summarized and exemplified with the individual cases that we have, they can have a strong impact on your H-index, as shown by some of those recent papers as well as Betsy's own papers. Also, the benefits of becoming involved with networks of collaborators, be they here, be they basic scientists in our department, fellow laboratorians in our department, larger consortia such as Children's Oncology Group, but the importance of reaching out to other people. That has actually been shown that reaching out, even considering publishing internationally, has a marked effect on H-index. But I think one important take-home message is that the H-index reflects part, but not all, of the scientific impact of a researcher's work. If you look at some of the changes in classification schemes or stratification schemes, that obviously has huge impacts that may not actually be well reflected in the H-index. And so I can't say that any better than Dr. Orr, and my volume has gone out. That's unfortunate. This worked when I tested it earlier. Please believe that. Well, bottom line, to translate what he's saying, we can lip sync here. He's essentially saying that his impactful research grew out of a pedigree, an interaction with a patient and their family. And over the years, that has now burgeoned into his area of expertise, his focus, what's driven his H-index, and now he's taken that to the next level by working with a pharmaceutical company to try to actually develop therapy for his disease. So a simple, quote-unquote, one-off case or a single interaction can have a tremendous benefit not only on one's H-index, but on one's whole career. And in fact, that is what he said makes him most proud, is the impact that he has had, regardless of the number of his H-index. But for those of you who maybe don't have Dr. Orr's H-index, there's always Dr. Oz. So with that, we'll take any questions, but thanks very much for your attention. And don't forget the
So I just want to just say one thing, and that is that the filming of Dr. Orr, although I know it looks like a very high-budget operation, had zero cost to it. It was done in One Button Studio. So if you just go online to One Button Studios, there are several of them around campus. There's one on the first floor of Deal Hall. You can sign up for a time, up to 4 hours per day for one group, and you go in. Everything is laid out for you. You push the button, you start, and then they send you an email with your video. So it's a very, very, very easy type of thing to maneuver. We did have some off clips of, we did do a couple of takes, but we'll spare Dr. Orr that.
Yes, Dr. Thompson.
I want to thank both of you. That was a fantastic presentation. Thank you very much. And it reminded me that there was a faculty member here, an ex-faculty member many years ago, who actually had a relationship with this department and actually made most of his academic career out of taking what he called experiments of nature and following through those experiments of nature. And certainly genetic changes are beautiful experiments of nature. And of course, his name was Bob Good. And so he set the stage for doing this kind of work. And I want to congratulate both of you. I thought that was fantastic.
One thing also to consider is particularly for younger faculty who are looking to increase their H-index, there are a number of ways in which one can do that. And I think knowing that Google Scholar, for example, will capture other types of scholarly activity, such as conferences, presentations, going to meetings and presenting your data, book chapters, review articles, all are things that can definitely have an impact on H-index. So try to keep an open mind. There's a lot of new metrics that are coming on board that deal with social media, online repositories, publicly available repositories of data, all of which can be captured by something like Google Scholar and can have an impact on H-index. So things are kind of slowly but surely turning away from just the traditional citation-driven metrics and moving into things that younger researchers probably are used to every day, such as tweeting and, being on blogs, for example. All of those things can now be captured. Yes, Dr. Furry.
Could you comment on e-publications? There are more and more electronic journals that are burgeoning. I would say that once or twice a week, I get an invitation to be on some journal I've never heard of. That's new. I'm sure many of you have the same experience. And then a quick question then for Dr. Hirsch. Were the patients with the BRCA mutations, were their data deposited in the initiative then as the BRCA exchange, or do you use that database ever?
For your first question, for open access journals, I mean, there is obviously a lot of discussion back and forth as to, are you doing an end run around peer review, for example? Although some of these new metrics that are coming out that are called alt metrics or alternative metrics, it's another synonym for that is kind of crowdsourcing peer review. Because as these open access journals are available, the key is accessibility. The more accessible you can make your work, the more you'll be cited, the more your H-index will increase. So if you're purely driven by H-index, yes, open access journals are great because they're easily accessible. They're freely accessible. People aren't behind a firewall of their institution that doesn't subscribe to this. However, one thing to bear in mind is that we know from being laboratorians that we shouldn't chase a number. And really what you should be chasing is impactful science. And do what you love, the money will follow. There's a lot of, talk about that. That's not always true, by the way. But do what you love and your H-index will follow, really, as I think Betsy has shown.
I think, actually, Pat, your question was one we asked Harry Orr. What should we, Harry, how many of these must you get? We have the same issue. And I think for most of them, one of the other things is actually the impact factor of the journal. So if you go into Google Scholar, you can actually look at the impact factors. They have something known as an H5, which is essentially like the H-index, but over 5 years, the number of papers that has been cited a minimum number of times. And that's something that, and so most of those open source journals are not in any of these classic, as Michelle has mentioned. It is something, though, that Michelle and I have talked a lot about amongst ourselves, between ourselves, in terms of where to publish. Because we ordinarily would go to kind of a cytogenetics journal or a subspecialty journal. But what this tells you when you look at some of these impact factors is that it's probably better to put it into a broad-based clinical journal that has a very high impact. And certain open source, like PLOS ONE, are certainly very, very high impact. With the second question, with respect to depositing into the database, that, of course, was not my call, especially with respect to the minors, but I believe that all of these were deposited. I didn't mention, but one of the issues was that the reason you can get biallelic mutations in BRCA genes is because one is classic and knocks out function completely, and the other is kind of a hypomorph, and you have some function. So they were kind of variants of unknown significance. I think that functional genomics is really what is going to be a critical piece here, identifying that now that you identify all these mutations, that these actually function in some model system or human to actually give you, or potentially give you pathology.
What's considered a good, better, or best score?
And I'm not going to go there because it differs so much even within a single field.
Pathology.
Well, I still don't want to comment on it because, and even a lot depends on, like you, for example, you're in a very specialized field. There may be fewer researchers who are actually in your specialized area who are able to cite. So looking at your H-index does depend a lot on context, and it's not equally applicable even in pathology.
Well, then how do you make an assessment on whether your H-score is any good?
I don't have to make that assessment. Dr. Firk probably makes that assessment for you. I don't know. Even George Hirsch, in his article, says this is one factor. It should not be used as a standalone in terms of judging whether one is promoted or any other life-changing event in a career. You can Google yourself and say, what is a good H-index for pediatric pathology, and you'll get a number of hits, but people are going to differ in terms of what's good.
Michelle, at the promotions committee meeting last year, Dr. Khalifa asked me about what do you think about so-and-so's H factor that wasn't very high, of an individual going up for promotion? And I said, I recognize what this person has, but I personally don't like to define us, myself, or anyone by his or her H factor. That is not what I want on my tombstone. Really, I think we have to be very balanced about this.
So you mentioned class 1. It's ironic, it's got a high impact factor, but to have an article accepted in class 1, it just has to be technically correct, independent of potential impact. So,
Say that again, Jim. I'm sorry, what was your point?
that's my point. So class 1, the journal has a high impact factor.
Right.
But in order to have an article accepted there, it just has to be technically correct, independent of what the perceived impact is of the study. So you have a high impact journal publishing technically correct things that may or may not have a high impact in terms of their topic. So,
It's only it's 3.1 or 3.2.
well,
So,
okay.
Yeah,
I
it's
can bring
not
that up.
very-
I mean, it's good. It's high for the fact that there's no consideration of impact. I mean, certainly it's the highest journal that out there where you can get pretty much anything accepted as technically correct.
Right.
Absolutely. But I mean, it's not like the really PLOS Medicine's got an impact factor of 13. There are other PLOS journals that have very high impact factors.
And of interest, some of the most highly cited articles in that top 100 paper article
Oh,
are
absolutely.
methods-based articles. So that's one other thing to consider is don't necessarily think that all of your papers have to be on patients. I know that, for example, there's been some recent articles from our department on validation of NGS, for example. Some of those types of articles could be among the most highly cited.
I have a question. Correct me if I misunderstood. So age is the number of papers cited more than the number of papers you have. So you cannot decrease your age index
With time. It can only go up with time.
but you can decrease it by publishing papers that never get cited.
No, you can't decrease it.
I think you can because
No,
let's
it
say
does
you
not.
have 20 papers and you have 20 citations. Sorry, you have 120 citations. And then you publish 100 more papers that never get cited.
No,
And
it's
you
not a
bring it
ratio.
down.
It's not a ratio.
It's
It's
not
out
a
of your total paper.
No, it never goes down, Bartek.
But alternatively, if you have one paper that's cited 1,000 times and you have 90 papers that are cited one time, your H index is 1.
Right. I mean, I think that
You got the whole scholarship.
Michelle did a lot of research on different indices, and there were other types of indices that actually do take into account more recent papers in terms of like a publication per the last whatever number of years versus earlier years, but not the age.
So maybe I was
Not the age index itself.
There's actually 39 different indices.
Is there a cyclonic complementation group H?
Is there a FANC H?
Is there a FANC H?
Because it was not on the table.
So FANC H, I believe, is the one that was removed.
Okay.
It was considered, it was thought to be allelic. It was thought to be different than another subtype, but then it was found actually to be the same as another FANC subgroup. So that designation was actually removed. And unfortunately, I am not remembering which one it was, which of those 20 it was allelic to, but it was essentially an allelic variant, and so it was removed from the classification. The other thing I think would be interesting to hear from some other people is, so Michelle and I this past year spent several torturous months writing a chapter in a book. That seemed like a good thing to do at the time, but I have to say now, I think writing review papers, you know, journals are also vying for their own H5 factor or their own H5 index. They want to have an impact. They want to be there. They know people are looking at this. And I actually think review papers for us might be a much better way to go than a book, which, quite frankly, in genetics is outdated by the time it gets to print anyway. So I know there are more senior mentors, even than myself here, to just comment on chapter, let's say mentoring a junior faculty to write a chapter versus writing review articles.
I
I think, thank you for the discussion. The discussion today was very educational, but it highlights a concept that maybe all of us embraced early on in our career. In the earlier segment of one's academic career, one needs to be smart. The day only has 24 hours, and you have a very limited, very finite amount of energy. So I think, at least I have always adopted the philosophy that in the early part of the career, I have to be smart how I can invest my energy, because the goal is to get promoted. If the goal is not to get promoted, then probably academia is not the right place for us. So if you want to be promoted, you can't afford to do what you like. You need to like what you do. You need to like being promoted, and you need to work towards getting promoted. As you mentioned earlier, you do what you like and money follows later. That probably is in the later part of your career. You can start writing about things that you just like to write about. You may want to write book chapters later on in your career because you like them, you think they are important, but they are not going to get you really anywhere.
Dr. Clark, you had?
Well, I was just going to say that books also have impact factors in a sense. That, I mean, if you're writing for a text that may be in fairly common use, that's probably good. But if there's a lot of books that are just kind of vanity books, that probably does not really have much impact on your career. But I mean, a book that is considered a major resource for your field, I think that's certainly a feather in the cap of any institution, I think.
I think that also points out the fact that we do have such experienced mentors in our department that it would be good for junior researchers who are perhaps being asked to write chapters to seek out advice, expertise. Do you think this is a good career move for me at this point, or is this something that I should say no to? Because it is hard to say no. Yes?
So for many, many years, the data regarding citations has been accessible. But there's another parameter that's appeared in the last several years that I haven't seen evaluated in any of these systems, and that's downloads. So, periodically we get information from Web of Science or whatever about how many how many times a paper of ours has been downloaded, and that seems to be kind of a higher value parameter than actual citations. Is there any prospect that would be?
That's a good question. It's not something that I came across in some of the research that I was doing. I think that's a very good point, because it's something that must be tracked, but I don't know where it's tracked.
I mean, because it addresses the question. A lot of times it's a technique where there's something special in that paper besides just the title that is of value to people in the field.
Right. And I think altmetrics are moving towards that, and that's where you're going to see that type of metric come out, not your typical traditional H-index.
So probably people don't pay for the reprint thing, so that's going to go down.
That's right, yeah.
Yeah.
All right, well,
Thank
you all for